Good morning.
Hello. Deepak, good morning.
How are you?
Hello.
Yeah, we enjoyed your first surgery.
Oh,
And what is this case now?
so this case is a known case of atherosclerosis.
Okay.
Why I'm saying known is, can you focus here? This patient I have operated other side 1 year back at Jaipur,
Okay.
and now she belongs to Agra. So she came to us. So I asked her to stay back there and kept in the workshop for the other year.
Okay.
Now, can you focus on the audiogram? She's a girl, 20-year-old, no? Yeah. 22-year-old, 24-year-old. Hello?
Yes, we can
Yeah.
hear you.
Is it focus on the audiogram?
Yes.
So this was the previous audiogram before first surgery. Can you focus on it?
Yes. Please
So
focus.
she had bilateral, moderately severe conductive hearing loss. Hello?
Yes, we can hear you.
Appreciable dip at bone conduction at 2K.
Yes.
Had more hearing loss on the left side, so we took up left ear 1 year back.
Okay.
And we used the same titanium piston with a laser stepidotomy. Now the present audiogram here. Can you focus here?
Yes, we
Can
can
you
see.
see the left ear airborne gap?
Yes, we can see very well.
So it is almost completely closed.
Yes.
And now we are taking up the right ear, which again has a moderately severe conductive hearing loss. Since it is a proven case of atherosclerosis, that's why I told in the beginning it's a known case of atherosclerosis.
And you have shown us this audiogram. Even the Carrot's notch is not visible.
Yeah, carrot nose disappears
Yeah.
after the surgery. See,
Yes.
this is something for the people to know why carrot nose comes.
Yes.
That too in the bone conduction.
Yes,
Bone
please.
conduction has three components we all know, and one of them is the inertial component, where the mobility of the ossicular chain contributes to the bone conduction. So in atherosclerosis, when the mobility of the ossicular chain is gone, when the stapes is fixed, you get a dip in the bone conduction and that is maximum at 2K because the inertia of the ossicle is maximum at 2K.
Okay.
So when you operate and the ossicular chain starts mobilizing, when the incus mobilizes and the sound goes inside, so that bone conduction improves and you see the disappearance of the Carrot's notch. That gives a sense of improvement in the bone conduction with the Stapes surgery.
Okay.
That is how it is interpreted. Okay. Besides this patient has a typical type AS tympanogram. Tympanogram has a value. It's a relative value in diagnosis, not absolute. And it depends upon the status of the tympanic membrane before you interpret the tympanogram.
Okay.
Because in tympanogram, what you see as a compliance, suppose the tympanic membrane is thin,
Yes.
even if there is ossicular fixation, you may find a high compliance.
Yes.
Similarly, even when the ossicular chain is intact, normal, mobile, if there is thick drum tympanosclerosis in the drum, you may find a type AS tympanogram.
Yes.
So you need to interpret it in the light of tympanic membrane status, number one.
Okay.
Number two, the stapedius reflex has a great value. Obviously, looking at the pathology when the stapes is fixed, we can't expect stapedial reflex to be present, and that is classical of atherosclerosis. Now, sometimes, not in this situation, you may find situation where is conductive hearing loss in the lower frequencies with hardly any loss in the higher frequencies, and those cases are kept for the atherosclerosis surgery by mistake because of the audiogram.
Yes.
Those are typically the third window lesions which present as conductive hearing loss,
Yes.
like superior canal dehiscence and all those lesions. Maybe in the Paget's disease sometimes because of the dissipation of the sound. So what happens in the superior canal dehiscence? What will happen? The sound goes to the inner ear and it dissipates rather than going to the round window and round window bulging out. The sound goes and dissipates through the another window in the labyrinth, and that gives a source of conductive hearing loss. That you can call it as an inner ear conductive hearing loss.
Okay.
And how can you easily differentiate from atherosclerosis? you need some tests. Simply, in autosclerosis, there is rigidity in the ossicular chain. So, you won't get stapedial reflex, which will be typically positive in semicircular canal dehiscence.
Yes.
The vamp will be almost absent at very high threshold in autosclerosis, which will be at the supra-threshold level in the third window lesions. So these are certain tests. Autoacoustic emissions will be absent in the autosclerosis, may be present in the superior canal dehiscence. So you need to correlate with many investigations clinically to reach to the diagnosis of autosclerosis, wherein you find this kind of a conductive hearing loss with a notch at 2K in the bone conduction, with a typical type AS audiogram in light of a normal tympanic membrane, and that too most of the time bilateral in females, most of the time, it's not always. So you have to corroborate all these things to reach to the diagnosis, but the final diagnosis is made after exploration.
And even in lower frequencies, if the malleus head fixation is there, then the conductive loss in lower frequencies is always
Yes,
more.
sometimes you get lateral fixation of the malleus in the atic, and you may take the case assuming autosclerosis,
Yes.
and then you find the stape is mobile and the malleus fixed, and then you have to go to the atic and release the malleus by means of a laser and put a silastic. So that's a different story. So by and large, we'll explore it, examine the ossicular chain as a whole, and see it on the other side is already autosclerosis. So we are assuming the autosclerosis on this side. Now, coming to another investigation, CT scan. We recommend CT scan, and we find that it's always good to have a CT scan in a patient where you are assuming autosclerosis. It's not for the diagnosis of autosclerosis, more of because the diagnosis in autosclerosis, there is a very small focus at the fistula anterofenestrum, which is hardly visible with a normal CT scan. You need to have a 0.5 mm CT scan to find that. So CT is not done to find the autosclerosis foci for the other regions. If there is an extensive autosclerosis involving round window, or if there is autosclerosis involving cochlea, then the value of CT scan is important to classify the lesion. At the same time, it is more important to evaluate the things pre-operatively which can complicate your surgery. CT is more important for them. For example, if there is dehiscent prolapsing facial nerve, which you don't know before, and you explore the case, the facial nerve coming out the over window completely, that complicates your situation and preclude your piston insertion. And in that situation, if you know this beforehand by CT scan, which can clearly depict how the facial nerve is there in particular situation, and you will be more prepared to do that situation, more prepared to tell your patient about the outcome, that you may have to abandon the situation. Now there are ways to deal with situation. That situation you can do a promontory drilling and below the inferior edge of the foot plate and put a piston. But that is a difficult situation, and that the CT will warn you and you will be much more prepared. Secondly, if there is round window autosclerosis involving anywhere in the inner ear, that you can tell your patient, and that you can give a guarded prognosis in that situation. Another important thing is,
if you tell us on CT scan where we will see the round window autosclerosis, where we will see the dehiscent facial, that will be good.
Give me a needle. This is a 1 mm scan, but still we see a lot of findings here. So I will take you through this normal CT scan in this patient to orient everyone.
Actually, Dr. Satish, Satish, we already means we heard a lecture on CT scan
so
temporal bone.
Not going to that part.
Related with this.
Autosclerosis only.
Yes.
Now, number one thing about the autosclerosis surgery, look at the size of the intra-aortic meatus.
Yes.
In situations where there is malcommunication between the inner ear and the CSF fluids, that can lead to a situation like gusher when you take up a case for autosclerosis surgery. You need to see the intra-aortic meatus, number one, the vestibular aqueduct, size of the vestibular aqueduct.
Yes.
Last month I demonstrated a case of cochlear implant in Jaipur in auto-ride. That was a case of Mondini's dysplasia with an enlarged vestibular aqueduct, and we had a oozer, not a gusher. So that communication gives oozer, but the enlarged Intra-artery meatus with a defect in the base of the cochlea can lead to a true gusher. And we need to know, Deepak,
Yes.
3-4 years back we did a Stapes carnival in Jaipur, 50 Stapes cases.
Yes, I was there.
We came across, you were there, we
Yes.
came across gusher. You remember?
Yes.
So, and we didn't have a CT scan of the patient before, otherwise we could avoid that situation.
Yes.
So, you need to see all these things. Number 2, the facial nerve anatomy. Can you see the tympanic course of the facial nerve?
Yes.
All the way?
Yes.
This is the genu of the facial nerve, and that's the vertical course of the facial nerve. Can you see all these? And this is the tympanic course of the facial nerve. Now, below the tympanic course, see here jumping by 1 millimeter. This is not 0.5 millimeter. This is the region of the oval window. See now?
Yes.
We are coming from above downwards. What is there below the tympanic course of the facial nerve? That should be the oval window. Can
Okay.
you see here?
Yes.
And this is the vestibule. Can you
Yes.
see the vestibule here?
Yes, very well
How
seen.
do you define the vestibule here on CT scan? See, comes from above downwards. That's the lateral semicircular canal. Can you see?
Yes.
And lateral semicircular canal opens in the vestibule here.
Yes.
See, this is the vestibule.
Yes.
This is the vestibule, and this is covered laterally by the oval window here.
Yes.
Can you see here?
Yes. Yes.
Very clear?
Very clear.
So that area has to be seen in a good CT scan. If you have an obliterative focus, completely obliterating the oval window, you can easily pick up on a CT scan. And then again, it calls for experience, and then again you are much more prepared to handle with that situation if you know that what you are going to do with, and you can tell your patient that you have a difficult situation and give the prognosis, guarded prognosis about the outcome in case anything goes wrong. Now, the third thing is persistent stapedial artery. In our series of our 4,000 Stapes surgery done till that, we have come across 3 cases of persistent stapedial artery. Though it's a rare situation, but by means of CT scan, you can have a gross idea that this patient could be having a persistent stapedial artery. Deepak, why I'm telling,
Yes.
the otosclerotic foci, the prolapsed facial nerve, the abnormalities of the ossicular chain incus, the persistent stapedial artery, these are the situation if you don't know before, you may have to cut a sorry figure when you come across such situation intraoperatively and ultimately abandon the surgery. So if you know all this before, you can avoid those situations.
And can
Persistent
we-
stapedial artery, let me tell you something, you cannot pick up on a CT scan. There's a fine artery passes through the crura of the stapes. So what happens? How can you get to have an idea that the patient might be having a persistent stapedial artery? This is a branch of internal carotid artery. From the vertical petrous carotid, coming across the promontory, it passes through the crura of the stapes and then enters the facial canal.
Okay.
And then it is destined to go intracranially to supply some area of the brain and the dura, which is destined to be supplied normally by middle meningeal artery.
Okay.
So this anomaly occurs when in the fetus, this persistent stapedial artery, which is normally absorbed, and the middle meningeal artery takes place, the job of the persistent stapedial artery. If that doesn't happen, this persistent stapedial artery remains and there is no middle meningeal artery. So how can you get to an idea on CT scan? Number 1, there will be no foramen spinosum through which the middle meningeal artery passes. Number 2, hello?
Yes. Yes.
Number 2, you will have widened facial canal through which this artery is passing along with the facial nerve. So if you find a broad facial canal in this region where you are suspecting otosclerosis with no foramen spinosum, that gives you a very good indirect clue of
To
persistent
what
stapedial artery.
level you advise these cuts? Means how you will see the foramen spinosum in these cuts?
Yes.
Please
If
show
you have
us
a good
where
axial,
is- Yes.
I can show you. Give me another axial. Aur do bada. See, this is the sphenoid. Can you see?
Yes.
Behind the sphenoid, when the petrous bone starts,
Yes.
Hello?
Yes. Yes.
at the junction of the sphenoid, petrous and the occipital bone is the foramen lacerum.
Okay.
And behind the foramen lacerum in order, where the pterygoid plate ends, is the foramen ovale, and behind and lateral to the foramen ovale is the foramen spinosum.
Okay.
In a very good CT scan, we can take up all these things. I don't have other.
No, it's okay. Just why I am
Yeah,
asking so
if,
that how what
there are
we
other things I
advise
will
is
show
for the
you.
radiologist to include the foramen spinosum area also. We
Yeah,
advise
that automatically
Okay.
gets included.
skull
There's a
base they
fine
include.
section done. Yeah, in those scan, if you go lower down, you will see all these foramens very clearly. Another scan.
And can we make the diagnosis of obliterative autosclerosis by CT?
Yes,
Okay.
then you need to have a 0.5 mm scan.
Okay.
Very clearly we have made several times. Another thing you need to see look into the CT scan is any vascular anomaly. Though in the autosclerosis surgery you are not concerned with your area of focus is the posterior superior one, but yes, if there is very high jugular bulb or anything which can complicate, that's rare to see. You can make out very well on a CT scan. So CT scan gives us additional information
Yes.
and prevents us from intraoperative surprises.
Yes.
That is the role of the CT scan. It's
Okay.
not that mandatory to get a CT scan. Most of the Stapes surgery have been done in the world without having a CT scan, and those surprises we see in the literature mentioned. And now worldwide there is a trend more and more about getting a CT scan done before autosclerosis surgery, because this has immense value. It's not that it is useless, and it has a value. It's not that you can't do Stapes surgery without CT scan. You can do it, but then you may have to face surprises.
Where you feel the CT scan is mandatory in conductive hearing loss?
Any patient below 16 years of age having conductive hearing loss, we always recommend a CT scan
Yes.
in pediatric patient.
Yes.
And we have seen that, witnessed in our Stapes carnival, all those 3 patients with gushers were the younger patients. And one of the patient was amazing. We got the CT scan done later on, and it was, what it was,
Yes.
the abnormal communication, because it was enlarged vestibular aqueduct. It had a cochlear base defect. That patient had a mixed hearing loss. That was a case of IP3, and that situation leads to, when there is abnormal communication with the CSF, that leads to a situation of persistent intracochlear hypertension or intralabyrinthine hypertension because of abnormal communication with the CSF. So moment you make an opening in the oval window, it bursts and the fluid is released. So that persistent situation of hypertension leads to diminution of the movement of the Stapes foot plate with the sound, because there is underneath the foot plate is a high pressure, and that gives you a false picture of conductive hearing loss.
As you said, age below 16 years, we must do the CT scan.
Must.
And it is like in unilateral conductive hearing loss, what's your opinion on that?
See, it depends so many things. You have to relate clinically also. See, once it comes to CT scan, in certain situation, if you find that you can get some additional information on the clinical history of the patient, by CT scan, if you can get additional information, just go in for it.
Okay.
In this era, it's not a matter of debate that whether to get a CT scan done or not. If the patient has a history of trauma in the past, must get a CT scan done. Simple.
Yes, yes. Is the patient under local or under GA?
All ear surgery we do under local.
Okay.
Regional anesthesia with good sedation and preparation. Now, are you getting the picture? इसको ये लो.
Yes, yes, we are getting
पूरे वाले को
picture.
कर टाइट कर. हाँ, Deepak,
Yes,
let
boss.
me know about the picture. We are not still our sensor vario microscope had some issues.
The picture is clear.
I am
We are
with the-
seeing the canal and the eardrum.
Yes.
Yes. And there is small bleb on the posterior superior aspect of the
Yeah,
canal. Not
probably.
much.
Because
Yes.
of this infiltration.
No, but it's good.
Yeah. Now,
And
about
just
the approach.
start telling us from how to avoid that bleb also.
Yeah, that comes from infiltration, and you have to be careful. always infiltrate under microscope in the canal. And infiltrate, see this is the bony cartilaginous junction.
Yes.
And here infiltration should not, your needle should not be steep down. It should be oblique to infiltrate in the subepithelial space at the junction here.
Okay.
Not into the epithelium of the bony canal.
Okay. And when you move your speculum in and out, then you will see that tightly adherent skin and the loose skin of that area is also.
Yes.
Yes.
So now about the approach. We almost always do with a transmeatal approach. Even in the narrow canals, you can carry out. Little more experience is required, that's it, but can be carried out very well. Now, our area of interest in this surgery is posterior superior region.
Yes.
Okay? So our flap elevation, the flap is designed in such a way that we get a full exposure in that region. So my incision is again, I would say the most simplified incision I am going to show you. Don't complicate your life in these incisions at all. See this?
Yes.
That's the level of the annulus. My incision is almost 5 to 6 millimeter lateral to the annulus.
Yes.
And this is just a horizontal incision. First one is horizontal incision, that too in the multiple goes. See that?
Yes.
Never try to go in one go, otherwise you may result in tearing the flap.
Yes.
Here it is the flap. See?
Yes.
You have to be careful here. Go in the multiple goes. See, mine is a horizontal incision.
Yes.
Anteriorly, see now. It becomes curvilinear, little medial.
Yes.
I keep an option for this incision to extend anteriorly.
Yes.
Far anteriorly, in case many a times you find the anterior malleolar ligament fixation, and to deal with that you need a exposure in that region. I can completely expose the anterior malleolar ligament with the same incision.
Yes.
I'll show you. So this is important. See this?
Yes. For the beginners, you please tell us how you decide this is 5 to 6 millimeters away from the annulus.
Yeah. See this? Your round knife. Can you see this?
Yes.
My round knife is 3 millimeter.
Yes.
2 round knives. That's it.
Okay.
And you get an idea boss with time that where you are making your incision.
And we want to extract more tips from you.
Oh, most welcome. And see now, I have focused inferiorly now. Deepak.
Hello Satish.
Yes sir.
I'm Dr. Chadbar here.
Hello sir. Good morning.
Good morning sir. Good morning.
मेरा गिफ्ट लेके आए हो ना सर?
गिफ्ट लेके आया, आपका स्टेफी ड्रिल मेरे पास पड़ा है.
Thank
Okay.
you.
Okay, thank you.
अब तो और कुछ गिफ्ट सोचे सर.
Deepak.
हाँ बॉस.
Now I have focused on the inferior part of the incision. See this?
Yes.
Here I am. See, my area of interest is not inferiorly.
Yes.
So here I am going to make a release incision, vertically release incision.
Yes.
Can you see that?
Yes.
And limit my exposure down here and release this tenting as I raise the flap. See this?
Yes.
This is inferior.
Yes.
I hope it is clear to everyone.
Very clear.
So superiorly I didn't make a release incision because इससे बड़ा लेना speculum एक size और. Because superiorly I may have to extend my incision anteriorly.
Yes.
Always use the largest possible size of the speculum.
Yes.
And I love the speculums. I bought once what Robert Vincent uses. That is amazing malleable speculum of all the sizes, incremental sizes by 1 millimeter.
Okay.
So that is malleable that you rotate, push the speculum inside, and which is the largest possible fits in perfectly is the speculum, and then you don't have to keep your hand to stabilize it. That is amazing.
And what you infiltrated?
The same 1:2,000 lakh.
Okay, ready-made.
Ready-made.
Yes. Okay.
In the canal and one infiltration in the incisura region and one in the post-auricular region.
Okay.
Now see, I am reaching the chorda level. Is it visible?
Yes.
Is that clear?
Yes, it is clear, little bit hazy. I feel it is on the lenses. If you wipe the lens with, otherwise it's okay, we can see.
See now, I am reaching the annulus level now. Can you see my annulus clearly?
Yes, yes.
हाथ को भी बाहर कर लो. अरे कोई हेजी है तो क्लीन कर दो ना भाई. तुम भी तो सुन रहे हो ना ओटी में. See inferiorly.
Yes.
Where my incision, I want to use that inferior exposure till I made the incision completely, so there should be no tenting.
Yes.
See now I have opened the mucosa
Of the middle. Yes.
middle ear, medial to the,
Annulus.
yeah.
Yes. So you enter just below the mesotympanum usually, this chorda?
Yes, that is
Okay.
called above. Can you see that?
Yes.
We must make all attempts in the Stapes surgery to preserve chorda.
Yes.
In the CSOM, doesn't make much of a difference because the chorda is already involved in the inflammatory process most of the time.
Yes.
And this is proven histopathologically.
You means other way is notch of Rivinus. You don't prefer that?
Yeah, you can do that.
Okay.
But see, now I kept my flap below.
Yes.
See, it is now never going to come during my surgery in my way.
Yes.
See that?
Yes, yes.
Our area of interest is now here. See that?
Yes, very clear.
My malleus is here, anteriorly here where my suction is.
Yes.
See that? That is my malleus.
Yes. Actually picture is hazy.
And here is the tip of the long process of the incus. ये जरा हेजी आ रही है उससे. नहीं इससे करूँगा मैं. रुक जा. I will do that. दूसरा निकलवा दे. End है क्या वो?
Lenses are clear.
हाँ.
Yes, now it is clear.
Clear?
Yes, yes. It
चलिए
is
मैंने
clear.
तो मैं तो. Now see what I can see
Yeah,
till
even
at this stage.
Yes, dome is visible now.
Yeah.
Little bit, yes.
That is my malleus here. See that?
Yes. Yes.
And that is the long process of the incus. Glimpse of that.
Yes.
Okay?
Yes.
Here is the chorda tympani.
Yes.
Here.
Yes.
See that?
Yes.
And this is the bony overhang which we need to remove to expose our area.
Yes.
And that is the round window region.
Yes.
Okay?
Yes.
There is overhang on the round window.
Yes.
That we'll see in the, this region we'll explore in detail in the next case of cochlear implant.
Yes.
Now, the exposure is very, very important to define. Why we need exposure? We need to see the pathology, the oval window completely, the surrounding region, importantly the facial nerve, and at the same time we need to remove this bone to have more space to manipulate our piston. So to maneuver the piston, you need more space. Now, coming to this overhang, there are many ways to remove this. You can use a simple micro drill. You can use a curate, like what I am using, and see the direction of the curate should be away from the critical structures. Yes. And you have to be careful about the chorda tympani while curating. अरे काला काला क्या लग रहा है इसमें? देखना गंदगी. This chorda comes out of this from behind through the chordal eminence. Many a times this chorda tympani becomes a big trouble in the exposure, and then what you can simply do is you have to drill away the chordal eminence and retract it little inferiorly. That makes your life very easy. Now, this is my Karl Stoll's curate. See the same curate I am using for last 10 years. And this is as sharp as ever. Deepak,
Yes, boss.
can you see the curate?
Yes, yes.
That's the beauty of this curate.
But actually, I am using Kalilkar since 15 years.
What? Kalilkar?
Yes.
Huh?
Yes, yes.
Great.
I feel it is the wrist power that is also very important.
Yeah,
here.
yeah, yeah.
Yes.
That is also important. How do you use the instrument is equally
Yes,
important.
Yes.
अरे यार ये साफ करने बंद पड़ा है that one forceps पतली. So other besides this curate, what else you can use? You can use a micro drill.
Yes.
You can use a micro mallet and gauze.
Yes.
Ashim gifted me that micro gauze and mallet, and that's amazing.
Yes, yes, no doubt.
In few strokes, you remove this overhang as a whole, complete.
And they replaces that bone piece again sometimes. That Professor Desai used to replace that piece again.
Yeah, you see, this reconstruction of this defect is not always required.
Yes, yes. No, as you said about the that.
Yeah, I'll tell you when it is required.
Yes,
I'll tell you first what is the ideal exposure.
yes,
Number one, it's not hard and fast. You should have enough space to maneuver your piston.
yes,
You should be able to see the foot plate completely, maneuver your piston thoroughly. That is important. And roughly, how do you achieve? Posteriorly, you should, when you are able to see the pyramid, you can imagine that you have good space you have gained.
yes,
Okay?
yes,
Can you see the stapedial tendon below?
yes,
See the glimpse of the tendon?
yes,
Clear?
yes, very clear.
And same thing is superiorly, you should be able to see the facial canal, fallopian canal.
Yes,
That gives you an indirect idea that you have enough space to maneuver your piston. Number two, the essential thing is, you are not supposed to expose the body of the incus.
yes,
That can be detrimental and that can start the problems. Reason being why I am saying, can you see the fallopian canal above?
yes,
See the foot plate?
yes,
If you expose this body of the incus by too much of curettage, that tympanic membrane can come in contact with the body of the incus and that can lead to retraction. So the problems arise when only the body of the incus is exposed. Otherwise this defect doesn't need any reconstruction by and large. Doesn't give any problem. See my superior exposure, Deepak,
yes,
with that horizontal incision.
yes,
See that anteriorly, anterosuperiorly here.
yes,
If I want to expose my anterior malleolar ligament in no time, if I remove it, elevate it, my anterior malleolar ligament will be there.
yes,
And the guide to that is, see this chorda.
yes,
This chorda run absolutely parallel and inferior, medial to the anterior malleolar ligament.
yes,
So when you deal with anterior malleolar ligament, beware of the chorda tympani, that you don't injure the chorda in that maneuver. I remember the time with the ABR Desai sir,
yes,
he would do an intraoperative audiometry in every case himself.
yes,
If there is slightest doubt about the issue, about the hearing gain, he would go and check, he will reopen, go and check the anterior malleolar ligament.
yes,
And that stiffness of the ligament because of the unused ossicular chain
yes,
sometimes contributes to the problem. Now see, sometimes these mucosal adhesions with the chorda. Okay?
yes, yes,
So the chorda is nowhere in the scene now. It is pushed inferiorly.
yes,
I don't want to manipulate chorda too much.
yes,
The stretching of the chorda is sometimes more hazardous than cutting it clean and sharp.
yes,
The reason being, there are many alternative test pathways to the glossopharyngeal, to the auricular temporal, to the connection with the fifth nerve, the 10th nerve, 9th nerve. There are many alternate pathways which
yes. As per
comes to play their role when the chorda is cut sharp. If it is too stretched, why that? Because the inhibition of the chorda tympani on the glossopharyngeal is deactivated.
okay,
But once you stretch, that inhibition is not deactivated, and that's why people call it that stretching is more hazardous than injuring it.
Okay.
Section. Now, can you see the foot plate completely?
Yes.
Now, we all know the fixed step of Stapes surgery, the all fixed steps. You have to disarticulate the joint, you have to make a fenestra, you have to put the piston, you have to remove the superstructures. And people have been doing in different ways. Some people do reverse stepedotomy, that you put the piston if you have good space and take the advantage of that fixity and remove the suprastructure in the hand.
Actually, Satish, I'm getting requests from the doctors who are sitting behind. Can you increase the magnification for them? Yes.
Yes. How is it now?
Yes, it is very good now.
Very good?
Yes.
Okay. So there are many ways to carry out the same things. Now, there is always a sort of insecurity about unwanted manipulation of the inner ear, damage to the inner ear at two steps. One is sclerotomy, another is fenestration. If you are doing mechanically, one cannot be so perfect always. Any movement transmitted to the foot plate can lead to problems. Like if you are doing a sclerotomy, fracturing the crura, you can bring the foot plate out if the foot plate is not completely fixed. You can lead to a fracture of the foot plate, you can do a partial dislocation, whatever, and anything such happens leads to some sort of sensorineural hearing loss.
Yes.
Similarly, fenestration. The same thing happens if you are using mechanical equipment. 90% of the time you are through if the foot plate is thoroughly fixed. But you can't expect every time. And that slight movement to the foot plate can lead to even to the submerged foot plates, all reported. Even we have experienced before laser. So I was looking for some tool for automatic carrying out these two steps. I tried almost 10 variety of lasers. And then I finally came into contact with this luminous laser, which has really changed the life. Deepak?
Yes, boss.
Amazing tool. I have no insecurity now carrying out these two steps with a laser that I can mobilize anything. It's absolutely no touch technique that you carry out fenestration and sclerotomy. Now, moving further, first we'll check the mobility of the ossicular chain. Can you see this blue foot plate?
Yes.
That's a favorable situation for the surgeon.
Yes.
There are three types of foot plate classified by Melafonte. A German surgeon had an article in Neurology long back. There are three types of foot plate from surgeon's point of view. One is a blue one.
Yes.
Blue is a favorable. Why I am calling it favorable? That the foot plate is fixed and the foci is involved in annular ligament, not the foot plate properly. And annular ligament is more fixed at the oval window margin to the foot plate. So when you do a fenestra or something, foot plate remains immobilized. Okay?
Yes.
That's a more favorite situation.
Is there any term, means you said the annular, the autosclerotic focus at the annular ligament, and
Yeah.
is there any term like the biscuit foot plate we say, is this?
Yeah, I am coming to that second grade. Second variety of the situation is in the type 2 foot plates, where the foot plate is partially, it's not blue, partially white. When the foci comes from the foot plate itself, and in those situations, the foot plate annular ligament is not completely fixed.
Yes.
And there if you make a fenestra, you can lead to problems. Okay?
Okay.
You can lead to even make it a floater.
Yes.
Now, the third situation is complete obliteration, when the foot plate is completely obliterated by the autosclerotic foci and the annular ligament is not holding completely, the annular ligament is not completely fixed. If you try to make a fenestra, it is going to get submerged. So in those situations, you have to be more careful. A laser is the answer. In the obliterative, yes, you have to drill away the obliterative focus first with a fine drill. Gently bring out the foot plate down, flush the foot plate, remove all the, drill out the autosclerotic focus, flush with the foot plate, and then use the laser for the fenestra. So, first of all, I am going to check the ossicular mobility. Now see what I am doing with my needle. See my movement, the lateral movement of the
Yes, malleus and
malleus neck, and see the mobility of the incus. Can you
yes.
see?
Yes, yes.
The incus and malleus are very good, mobile, no issues.
Yes.
Now coming to the foot plate mobility. Now I am focusing on the foot plate. Section,
By this maneuver, you will get any idea about the anterior malleolar ligament with experience?
Sometimes, yes. Sometimes it is very rigid and you don't have a free movement. You can have an idea.
Okay.
That could be a fixation of the anterior malleolar ligament.
It means as per you go.
Now see now on the foot plate. It is fixed.
Yes.
Can you see?
Yes.
Absolutely fixed. So as we were expecting, the diagnosis is confirmed now. Now my next step. Here I am having laser, so I don't have to go by any reverse steps. First step is disarticulating the incutostapedial joint. Can you see?
Yes.
Hello?
Yes, yes.
See now, where is the incutostapedial joint? I am going to mobilize this incus anteroposteriorly. Can you see the joint below?
Yes, submucosally, yes. It
Yes.
is appreciable.
So
Yes.
that is the site of the joint. See exactly where my instrument is in.
Yes.
This is important to know, otherwise you can damage the
Yes.
lenticular process. See,
Yes, yes.
this is such a simple step which people can complicate by not going right into the right place.
Yes.
Okay?
Yes.
Now my next step would be to vaporize the tendon. I can cut this tendon with a scissors. There is hardly any issue. It's not a critical step.
Yes.
But since I am using the laser, so I will just do a rehearsal with the laser how it is working and focus. Watch point 3. I will point 3.
You are not.
Eight watts.
You are not in favor of preserving the stapedi muscle or
It's-
tendon, and if not, why?
Deepak,
Yes.
what I said in the first surgery, I am a proponent of preserving the nature's anatomy.
Yes.
We have done a few cases with the tendon preservation,
Yes.
but finally we didn't get any benefit out of that. I don't know. Though the literature supports the number of benefits with the preservation. I tell you the practical point.
Yes.
Of the preservation of the tendon, the most important point is preserve the vascularity to the lenticular process and the long process of the incus which comes along the tendon.
Yes.
Number two, as we all know, the stapedius is an important muscle and we should respect the nature's physiology. It dampens the unwanted sound and limits the movement of the stapes down.
Yes.
So it protects from the unwanted high frequency sounds and other sounds, and it leads to a very good, ideally it should give a good speech discrimination in noise. But the literature is still no guidelines.
Even in the latest OCNA, it was mentioned the blood supply to the long process of incus comes from the bone marrow of the incus, not from.
Yeah, it comes from the bone marrow also. There are 3 vessels, I tell you, I'll quote you that paper. 3 vessels run through the core of the incus. And they run in the anterior inferior part of the incus. See here. I'll show you. Here, see this incus?
Yes.
In the anterior and inferior part, where these vessels come, and these are the source of blood supply to the incus. This is additional blood supply along the stapedius tendon. Now this is a gel foam piece I am covering the oval window with. Can you see?
Yes.
Now I will just first do rehearsal with the laser whether it is absolutely focused or not. You see now? Can you see the beam?
Yes.
8 watts. 8 watts. Watch क्या करेगा? 8. हाँ बस. Yeah. Yes. See now. Deepak,
Yes.
I am going to vaporize this. Ready?
Yes.
Can you see? Can you see?
Yes, we are seeing, but if you can focus.
Yeah, it's gone, boss.
Yeah,
Tendon is vaporized.
yes,
See, the tendon is vaporized.
yes, we can see.
See now?
But
Now, my most important area where I use this laser, the two steps. One is craniotomy. I am always having insecurity if I fracture it and the foot plate is not fixed. By bending towards promontory, it can bring out the foot plate or make it floater.
yes,
And that is something important for the patient. The patient who has come for the treatment of conductive hearing loss ultimately goes back with a sensorineural hearing loss.
yes.
See this red gel from?
Yeah, can you focus on the cruras and the footplate of his stapes, please?
Yes. See, a foot plate I have covered with a gel foam.
Yeah, we know.
Crura you can see. Pakadna is- I will focus further. Let me know.
Yeah, no. Yes,
Now.
it's okay now.
Crura you can see. Now the situation you have to be, the extra care you need with the laser is, see this laser is the only one which I have seen with a calculated delivery of the beam of whatsoever size you want. You want, like standard I use 0.3 mm size, delivery of 8 watts with exposure time of minimal, in what sequence the continuous super pulse, whatever you can use. So now, another important thing you need to take care in this situation is covering the foot plate, that your shot should not go unwanted on the foot plate. Number two, I am very, very careful while using the laser in the situation when the the fallopian canal is decent. Can you see this?
Yes,
Absolutely intact. When the prolapse facial now, I would recommend not to use the laser, just to be on the safer side. Now, coming to the crura, we all know the anterior crura is very fragile. You can easily fracture without transmitting any further pressure on the foot plate and get away without any problem. See the posterior crus. Posterior crus is always stout and thick. And that removal of the posterior crus is the source of problem if you are not careful. So what I am doing again, can you see the focus?
yes.
बस सही है 2 कर दो इधर या ठीक है
Where exactly you vaporize on the...
at the lower end.
Okay,
See this?
yes.
कोई चल क्यों नहीं रही? एरर किसकी आ गया? Some error occurred in the laser. Can you see the process of vaporization which has vaporized the foot,
Yes, we
posterior
are.
crust a little bit?
Yes,
Can you see the whole stump of the posterior crust?
yes.
But I will further vaporize the laser stop somehow because of some voltage
But
issues.
by that time you tell us when you were not having laser, what you were doing.
You have many options. First of all, you can use a micro drill, fine micro drill and thin out the posterior crust,
Okay,
like the dimension of the anterior crust. Make it fragile
okay,
and then fracture it.
okay.
You can carry out a complete fracture with the drill also,
Yes,
with a skeeter now more control.
yes.
And we have our own Dr. Chatbar who has designed that skeeter, a very cost-effective tool. The first skeeter I bought was from Dr. Chatbar and it's still amazing. Though we have a Medtronic also, but there is no difference. But we hardly use skeeter. I use skeeter only in obliterative situations or sometimes when there is ridges on the foot plate that you have to make flat. Then you use the foot plate, the skeeter. Or when we have a facial prolapse, then I don't use laser. Ready? Yes, ready. Again, we are ready. That 0.3 चाहिए. Let me know when you are ready. Deepak,
Yes,
can you see the laser shots?
yes, we are.
अरे फिर बंद हो गई. चलो anyway, see now I'll remove the gel foam and show you what I've done. See that? The foot plate is, the crust is completely thinned out. Can you see?
Yes.
Can you see it is broken? Deepak,
Yes, yes.
see it is broken. Can you see here?
Yes, yes.
And the anterior crust we all know is fragile. You can easily break. Yes. And this suprastructure is now coming out.
Excellent. Yes, yes.
Nowadays they have a fiber also with this laser. See, the problem comes towards the anterior crust, where the incus is there in the way, and with this aiming beam you can't focus on the anterior crust. Okay?
Yes.
Using the fiber guided laser, the same luminous laser with the fiber, you can focus on the anterior crust. See this suprastructure coming out?
Yes.
See the long anterior crust?
Yes.
See this? Can you see?
Yes, yes. Excellent. We can see
The
that.
suprastructure out. Now the situation you see the foot plate area completely?
Yes.
See the foot plate.
Yes.
Now the question is, there are not many factors which have a role to play in carrying out a good Stapes surgery in terms of outcome. The number one is the site of fenestra. Okay?
Yes.
So where can we make the fenestra, and why this question arises? See, this foot plate is the lateral end of the vestibule. It closes the vestibule laterally. And underneath the foot plate at varying distances are the membranous labyrinthine structures. Anteriorly is the saccule and posteriorly the utricle. Okay?
Yes.
Now I refer you to the study done by Hugo Fish and published in 92. That was amazing cadaveric temporal bone study on 300 bones to measure the distances at the medial end of the foot plate. Okay?
Yes.
Straight wala de. From the foot plate medial end, anteriorly the closest structure is the saccule and posteriorly is the utricle. Now in that study, anteriorly, if you make your fenestra anteriorly, the saccule is roughly 0.7 millimeter away.
Yes.
If you make your fenestra posteriorly and superiorly, the utricle is same 0.8 millimeter away.
Okay.
If you make the fenestra in the center and little inferiorly, no membranous labyrinthine structure is within 1 millimeter from the undersurface of the foot plate. And that is the safest site for carrying out a fenestra. Okay?
Okay.
So best site of fenestra is in the center and inferiorly. Okay?
Okay.
In situation when the patient we have encountered many times, the foot plate completely overlying the foot plate, facial nerve completely overlying the foot plate over here. Okay?
Yes.
And what you can do? See the upper edge of the promontory here.
Yes.
In the center of the inferior edge of the foot plate, up to 0.3 millimeter, you can drill this promontory and make a fenestra at the lower edge. If you go beyond 0.3, you may enter and damage the cochlea. Okay? And that is the safest site at the inferior margin, posteriorly and in the center, not anteriorly at all. Okay?
Please repeat again what you said.
Hello?
Yes. Please repeat again what you said.
So if you have to make a promontory fistula in the case of foot plate prolapse, the facial nerve prolapse,
Yes.
what you can do? You can make a fenestra because most of the foot plate will be covered by the facial nerve.
Yes.
You can make a fenestra at the inferior edge of the foot plate, little posteriorly. What's my point?
Yes.
And that too, you can go up to 0.3 to 0.4 millimeter,
Okay.
drilling this promontory bone. Not more than otherwise, you can damage the cochlea,
Okay.
epithelium, the endothelium. Okay?
Yes. Yes.
There are many articles published to handle this situation of the facial nerve prolapse in the literature, and the simplest one is what I told just now,
Yes.
to make the fenestra the inferior edge. The other ways of doing it is to release the prolapse nerve inferiorly and then make a suprafacial vestibulotomy. Okay? The vestibule is underneath the facial nerve here and the foot plate. Okay?
Okay.
Now, so now we have a laser. Again, the fenestra will be. With this laser, the beauty is you can make a single shot fenestra. Now, there are variety of lasers in the market. The Argon laser, KTP laser, NDR, RBM laser, so many lasers. Lots of studies done. We have gone through almost 100 articles about the laser thermal trauma and the characteristics of lasers and pros and cons of each laser. And then finally, the CO2 is the most appropriate for the Stapes surgery. KTB, RBM, contact lasers have more. They are not absorbed by the water. So the laser energy passes through the vestibular perilymph to the membranous structures and more toxic. CO2 is a non-visible laser. Only thing is you have to use aiming beam and it is absorbed by the tissue and the fluid very well, the best absorbed. So what happens? This power of energy delivered to the foot plate for the fenestra is calculated in such a way that this entire energy would be absorbed by the bone and no thermal energy will be transmitted to the underlying perilymph, and still if it is transferred, the perilymph acts as a shock absorber. As a laser energy, the CO2 laser is absorbed by the fluid. So ultimately the membranous labyrinth is very well protected. Okay? 0.5 kar do. Deepak,
Yes, yes.
could you get what I am trying to say?
Yes, yes.
And recently was a great study published in the Craniofacial Journal about this, the trauma, the laser trauma. See, once this energy is transmitted to the vestibule, the temperature rises. Okay?
Okay.
Up to 7 millimeter of the temperature rise is safe to the membranous labyrinth. Beyond that, it is toxic. So, the study is done with a single shot 20 watt CO2 laser. The number of studies done, the temperature studied, and it doesn't lead to temperature rise by more than 2.5 degrees. It's absolutely ultra safe to the membranous labyrinth. Many times when the foot plate is little thicker, we go about to sometimes to 21, 22, even 24. But in this situation of the foot plate, you can see it's absolutely favorable, and I am using a classic 20 watt shot. Okay?
Okay.
Do karo. Do. Okay, can you see the beam?
Yes.
And see what I am making? In the center, in
And
the
inferior.
inferior part. Ready? Okay. Ready? Deepak,
Yes, yes.
keep an eye.
सांस रोक रखी है.
Yellow. Done. Can you
Yes,
see the
yes.
fenestra?
Yes, yes.
This is it's a 0.5 mm discrete fenestra which I made, and see the perilymph coming out.
Excellent, excellent.
Absolute perilymph sign.
Yes.
No damage of anything.
Yes.
No thermal damage.
No
And I told you we are done with this particular laser of 3,000 cases now. In our entire series of over 4,000 cases.
Yes.
With this luminous laser, it's absolutely ultra safe.
Yes.
Yeah, can you remove this? Boss, now
Just
we don't
I
need
want
laser.
to know, with this technique, even what we see, even in atraumatic fenestration by other methods, we see sometimes the high frequency hearing loss. So with this laser, when you started in your 3,000 cases, in how many percentage of cases you are seeing that high frequency hearing loss?
Not really, Deepak.
Okay.
I mean, to the extent that I can quote, if it is used properly,
Yes.
no way. See the vestibule open with no damage to anything, boss. We are miles away from the membranous labyrinth. It is full of perilymph. See that?
Yes, yes, yes. No touch.
No.
yes.
If you increase the power, obviously you can face problems. Number one, if you mobilize the foot plate by any means, definitely you'll have some sort of sensorineural hearing loss.
No, not by laser. I am means after you started using this laser,
Yeah.
you are not seeing. I mean to say you are not seeing any high frequency hearing loss which you used
really,
to see.
Not really.
Okay,
And you go through the article published particularly from the Jovanovski,
okay.
it's amazing tool. Yeah. So now, another thing, now the last thing left is to put a piston.
Yes,
And that is very, very important. You know, if you go back to the studies done on the revision stapedotomy,
yes.
what is the commonest cause of revision stapedotomy? Can you tell me?
That necrosed or slipped piston.
So, all piston related problems, over 3/4 of the revision stapedotomy, for the revision stapedotomy for the conductive loss is because of piston related problems.
Yes,
Piston causing incus, long process necrosing, long piston, short piston, all these things, displaced piston,
yes,
all those are the issues. The piston is a very, very important point, boss, in this surgery.
yes,
So, now I'll come to all the points related to the piston. Number one most important issue is the size of the piston.
yes,
Single most determinant factor of the Stapes surgery outcome is the size of the piston.
yes,
Single most. See, you saw the blood coming out of the foot plate,
yes,
Finestra, but see, it never enters.
going inside.
It never enters.
yes,
The pressure inside the vestibule is more than the pressure inside the
yes.
middle ear,
Yes.
so it cannot. So
Professor,
the blood can create problems, definitely, when you suck this fluid in the vestibule.
Yes,
So one is not supposed to suck this perilymph at all.
yes.
That is going to give problem for sure, bound to give problem.
Professor
most of
David Desai used to say bubble not broken.
Yes. So most of the post-operative issues of sensorineural hearing loss and vertigo, particularly vertigo, are related to this aspiration of the perilymph from the vestibule.
Yes,
So don't even touch it, just suck around it. Even if the blood goes, it doesn't go inside. If the vestibule is empty, blood goes inside and that is a problem. That is going to give permanent issues. So now the size of the piston is most important. The reason being, appropriate length is required. Now, how much length is required? This piston should not project. If when I made this piston, the fenestra is a lower center part. And here the membranous labyrinth is not less than 1 millimeter away. Now, my piston should not project over 0.4 to maximum 0.5 millimeter inside the vestibule. The reason being, number one, if it projects more, the endosteal membrane may not form and can lead to a permanent perilymphatic fistula. Okay?
yes,
Second thing is, if the piston is short to that level, it's not extending more than 0.34 millimeter into the vestibule, during the negative pressure maneuvers, like sneezing, sniffing, can bring the piston out. The Valsalva can bring the piston out of the vestibule as the TM is retracted laterally. Okay?
yes,
If it is more than that, the piston in the extreme pressure variations, like you are flying, driving, your piston can project up to 0.5 millimeter more into the vestibule. And this has been proven. I'll refer to the article that extensively studied the value of this screening for the military crews. The piston, what happens to the pressure change, the TM radial fibers, they work and bring the TM, retract the TM, and after certain pressure the TM becomes taut, like a wall. And that pressure leads to push the piston up to 0.5 millimeter. So if my length is more, it can go more, or the piston can go more in and can damage the membranous labyrinth. Okay? So piston length is the single most important factor. So how do we assess the length of the piston? Now the piston I've been using for many, many years is the Kurz titanium piston. Earlier I used to use the Teflon. Teflon is a good tool, but there are certain issues that led us to use this, move to this titanium which I am going to share with you. titanium is extremely biocompatible as compared to Teflon. So biocompatibility is no issue. The issue is the need of crimping, number one. I tell you why. See now, first I am assessing the size of the piston. So for this piston, the piston measuring gauge comes from the same company. For that matter, any piston you are using, you should have a measuring gauge from the same company. Because it's not a millimeter, it's a parameter. See this?
Yes.
Number of, the pick. I'll tell you something about this measuring gauge. See this measuring gauge?
Yes.
Where this is the flange which I'm going to push inside, and this is a bar to coincide with the incus. Okay?
Okay.
Now the lower end will go on the foot plate and we'll see where it coincides with the incus. That will be the final length, and that is measured here. See here, 1, 2, 3, 4 are the 1 millimeter. This thing, graduations.
Yes.
And then 0.25, 0.25, 0.25, 0.25, then 1 millimeter, 6, 7. So this company produces both the Malleus and the incus pistons, and that is amazing. I'll tell you the reason how it works. Now,
Yes, Satish,
Yes.
there is a question.
yes, please.
You do this measurement before making fenestra or after making fenestra?
See, ideally you should make before making fenestra.
Okay.
Now, in the thick foot plates, what happens?
And
In
is
those situations, you keep 0.1 millimeter to add for the thickness of the foot plate. Okay?
yes.
The normal thickness is 0.1 millimeter.
Okay.
So if you come across a thick foot plate and measure it as 1 millimeter, 0.1 millimeter, your calculation go wrong. Okay?
Yes.
So then we started measuring after fenestra in every situation. Why to discriminate? We don't know what would be the size of the foot plate, thickness of the foot plate. So I'll see how I measure it, and which part of the incus should be coinciding. Lower inferior part of the long process. See that?
Yes.
Absolutely coinciding the thickness of the incus. Can you see? Can you see?
Yes. Yes.
Why I'm saying the lower inferior part? If you see the studies are done on the incus morphology, there are many studies done. The thickness of the incus, where we put the piston is placed, you can say roughly 1.5 millimeter from the lowermost part of the incus where the lenticular process is. Okay?
Okay.
And that region, the thickness of the incus is 0.5 to 0.6 millimeter.
Okay.
Okay? So we measure roughly from the foot plate to this region to the middle of the thickness of the incus. So middle will be roughly 0.3 millimeter.
Okay.
Okay? Now if I glide this piston down into the foot plate, how much it is going to go in? Not more than 0.3 millimeter.
Okay.
What my point? Is it clear or not?
Yeah,
Hello?
please repeat again first.
See, I am measuring to the middle of the length of the thickness of the incus, where the incus is 0.5 to 0.6 millimeter thick.
Okay.
So the rest middle of the thickness of the incus piston is going to go in.
Yes.
So my piston in any way is never going to be an overlong piston. See, the small things matter in Stapes surgery. A fraction of millimeter can make the difference.
Yes.
What I want is, I don't want an overlong piston
Yes.
at all.
Yes.
Overlong piston is a disaster
Yes.
in Stapes surgery. So to ensure that my piston doesn't go overlong, the thickness, the size measurement is very important. And here we take the advantage of the thickness of the incus. I'll share that morphology of the incus article with you. The thickness here, 1.5 millimeter from the tip, where we use the piston, is 0.5 to 0.6 mm thick.
Okay.
So, if we take the half of the thickness of the incus for the piston to go 4.5. So this is 4.5 millimeter piston required in this case from our measurement. And here I am going to use the 4.5 mm piston and see that how it goes, and how we ensure that it is not an overlong piston. Okay?
Is this the measuring gauze
Yes.
which you showed us?
Yeah.
Is this manufactured by Kalilkar?
No, the same Kurj. My recommendation, whatever company manufacturer piston you are using, you should use the measuring rod from the same company.
Okay.
It's not the millimeter always, it's a parameter, boss.
Yes, yes.
Don't rely on the millimeters.
That's the same piston company code.
Now coming to the piston, why titanium piston? Let me show you my piston, which I've been using, and now we have used almost over 3,000 pistons. These, see this? Can you see this piston?
Yes, yes.
It's a clip piston.
Yes.
Uday, middle. So it's a very, very slim piston. My finisher was 0.5 millimeter, and my piston is 0.4 millimeter.
Okay.
So all around the piston will be the 0.05 millimeter space acting as an allunar ligament when the endosteal membrane forms. So this is the opening end of the piston here.
Yes.
There is a middle slot to hold the incus,
Yes.
and there is a bar to push the piston anteriorly.
Okay.
And this is such a slim piston. Now, why this piston? Why not Teflon? What all you need when you put a piston? It should be ideally holding the long process of the incus with no plate between the piston and the incus. So whatever sound is coming to the incus, it transmitted to the labyrinth. Ideally, you want this. Okay?
Yes.
Once you use a Teflon, how do you crimp? Can somebody, human being, do an ideal crimping where it should not be either under crimped or over crimped? One cannot. And there is always the fear of over crimping makes the surgeon do under job, and that loose piston applied on the incus, a loose piston keep on hitting the incus and leads to incus necrosis and remains the number one cause of incus necrosis, which remains the number one cause of revision stepidotomy surgery. Over crimping is same hazardous. Number one, it can damage the mucosa of the incus and anteriorly even the blood supply, strangulate the incus. At the same time, that process of over crimping itself is hazardous. If you try to crimp it tightly, you can dislocate the malioinguinal joint, and that's a disaster. So, I was looking for an ideal piston which doesn't need crimping. So this is the piston which holds the incus like a clip tightly, no play between the incus and the piston, and it holds only less than 30% of the circumference of the incus. And more importantly, it is so easy to use. Our junior most guy uses this laser in the piston so easily because it makes your life so easy. So this technique is so reproducible, so easiest. Now I'll show you. Yeah, I'll show you the piston. How I'm taking it.
Satish.
Yes, please. Can you see my piston here?
Yeah,
Going in?
yeah, very well.
Can you see the lower end of the piston?
Yes,
Look at the upper end of the piston.
yes,
Leave it. See the point? Where I want to crimp. See this? Lower end.
yes.
And this is the bar on the incus. This piston. Just you have to push in. That's in.
Yeah, very good.
That's it.
Very good.
It takes less than 15 seconds to carry out this step, which people I have seen struggling for more than 45 minutes with a Teflon piston. See that?
Yes,
It is holding like a clip, snugly fitting onto the incus, no play between the incus and the piston. See that?
yes.
See that?
Yeah, yeah.
And it's amazing, amazing piston. The Teflon is nowhere even close to it. I am not against Teflon, but if something is better, we should appreciate. I know the cost is a limiting factor. See that?
Yeah.
And now my cord is going to come over it. See that?
Actually, they are asking how much is the cost. I said for
Cost is 11,000 was.
I said for Satish it is 2000 and for us it is 11,000.
No, it's 11,000. Even I buy in 11,000.
Satish,
Yes.
Dr. Chadbaria.
Yes,
Now-
boss.
Now, what about the diameter of the piston? Does it matter if it is
Yes,
0.6,
yes. We need to discuss that.
Yeah.
We discuss the length of the piston, not the diameter. Now, theoretically, what is proposed? Bigger the piston, more it will displace the pedal limb, and better will be the hearing. Okay?
Okay.
Previously, to begin with, this surgery started with a total platinectomy, complete stapedectomy. And what happened? The hearing loss in the higher frequency was a big concern, and overall more hearing losses were observed because of the too much of displacement of the pedal limb. So
Yeah.
the world has resorted to a small fenestra. Now the small fenestra, there are a lot of studies done with the 0.4, 0.6, 0.8 mm pistons. So our philosophy to use the size of the piston in a regular situation to 0.4, and the results in the higher frequencies are always better with the smaller pistons than the larger pistons, number one. Number two, the comparative studies done with the 0.4 and 0.6 had hardly any difference in terms of hearing gain at the higher frequencies and the speech frequencies. And yes, the loss observed, overall long-term loss observed was less with the 0.4. Yes, the measurable difference was observed with a 0.8 piston. It displaces more pedal limb, but those patients have high frequency loss. Those pistons we use in patients who have mixed hearing loss, which require more displacement of the pedal limb for the better hearing. So I use 0.8 mm piston in patients with mixed hearing loss, not in the pure conductive hearing loss. Does that answer your question, sir?
Okay. And what's your opinion about tissue interposition?
Yes, that's an important issue. I am always proponent. I am not against the vein graft. I tell you very frankly, vein graft is amazing thing to cover the window, the foot plate, and seal the vestibule perfectly. Most of the complications, the long-term complication in the Stapes surgery happen to occur after a persistent perilimb fistula, which can sometimes even lead to a sudden sensorineural hearing loss. I have seen ABR Desai, who has been doing for last 40 years, consider him best in the planet. I have seen him doing more than 500 cases of Stapes done. Long-term results, even I see his patient 30 years back done, with amazing results. So vein graft is a good thing. Yes, in a situation like a total platinectomy happened to occur with me or anybody, vein graft has to be done. Partial stapedectomy done with half of the foot plate out, vein graft should be done. In a small fenestra, the endosteal membrane forms underneath the piston if the piston is not overlong. And next 48 to 72 hours, the endosteal membrane forms under the piston and it seals the labyrinth. If the piston is overlong, you can't help it. There is going to be a perilimb fistula. The most important advantage of vein graft, what I see in the practice, is if you cover with the vein, you can't put an overlong piston. That's the best thing. If you try to put an overlong piston, that will invaginate the vein inside, and that sign will warn you that you have an overlong piston. What's the point? Hello?
Yes, yes.
So, the beauty of the vein graft is it prevents you from using an overlong piston. And it covers seals the labyrinth definitely. And thousands of people have done this over the period of years, and it's a time-tested technique. There is no reason to condemn it except the frustration people condemning the vein graft. We need to understand the
You
physiology.
have done both the cases. Means
Pardon?
you use this titanium piston,
Yeah.
you use the Teflon piston.
Yeah.
You said about 3,000 cases you use this
Yes.
titanium
You
piston.
can inquire from the company
No,
how much I have bought.
no, I am not just doubting your. In how many cases have you seen the revision you have done of this after using this piston?
Titanium, I am yet to see a single one.
Very good. Okay.
Honestly.
Yes, yes.
And in a series of this Stapes, 500 are the patients which are revisions.
Okay.
Then We get lot of
Suppose in,
revisions.
in revision cases where the lower half of the long process of the incus was missing,
Yeah.
so there you use the malleus to stapes.
Yes, many a times you have to do a malleus stapedotomy, and this same company produces a ball socket joint piston.
Yes,
The
yes.
piston itself is a ball and socket joint. And that is amazing. You have to do many maneuvers. If you are doing malleus stapedotomy, vein graft is mandatory. Once it comes to vein graft, to your last question, then it is mandatory to me. The reason being, the range of motion of the
Yeah, malleus.
handle of the malleus is much more than the motion of the range of motion of the incus, because the malleal incudal joint curves that range of motion, which is not there in that situation, and then you must use the vein graft, otherwise the chances of sensory neural hearing loss are very high.
In next case, step is what you are going to defend. Means you have done this case, and the next one more step is there.
Yeah.
So what difference you are going to do in that case?
Let's see what is the case. I have not seen, boss.
No, you say
We'll do on the merit of the case.
okay, same piston or Teflon or another technique, or without laser, whatever is choice.
But what you are going to achieve with that?
Because 80% people are using not using laser actually. For them,
So it doesn't mean that I show some technique which I find inferior to what I have been doing.
okay.
What is the reason to that?
So next is means step is with the
No, actually, we want to see how you handle the Teflon piston, how you handle the perforators, and
Yeah.
you can give us the tips.
we have
Yeah.
a storage perforator with
Okay,
us.
let's see. Let me see the hearing loss in that patient.
He has a good almost 35 decibel.
Okay, I'll show you the manual one and the risk involved with the manual one.
Yes. We have with stores I think perforator with other thing. Just try if for
No
that.
issues, boss.
So I think
Satish,
Yes, boss.
Dr. Chadwar here again.
Yes, sir.
Now, do you do Rene test after surgery?
What?
Rene test on table.
On table we don't do. On table, yes, just we have a gross idea from the patient about the hearing. If that works well, in the post-operative period, we do the Webers.
Okay.
Rene is never reliable, it's the Webers which is reliable.
So, what you
The
get?
problem in the post-op period starts. See, if there is issue in the post-op period, it will be reflected by the patient in terms of symptoms. And I tell you the protocol, we get many referrals from the people who have done Stapes surgery, and the patient is amazing, severe vertigo, not responding to any treatment. What to do in that situation? And you know, most of the time, what is responsible? Long piston.
Hello, Dr. Satish.
Hello.
Yes, good morning.
Good morning. How are
So
you?
I am very fine. I just wanted to ask you one question.
Yes, please.
That you've been using Teflon as well as titanium piston. Do you
Yeah.
find the difference in results also?
Yes.
What is the difference?
Yes, the airborne gap, the need of revisions. The
Okay.
piston can get slipped, piston can erode the incus, and this is it's proven. You go to the literature and see, I can transfer you so many articles.
No, I mean both two cases where both are working perfectly. Teflon.
I see again,
So there is a difference.
from the beginning, when I started the surgery with the grommet, I told one thing, I am not here to criticize any technique. I have
Just
even
wanted
practiced.
people
I
to
have
know.
myself practiced all possible techniques mentioned in the literature, and then what I'm doing is I have found the best for the patient in terms of long-term results.
So you are the
No technique is bad. No piston is bad. I'm not saying that Teflon is a bad piston. This is a relatively better piston in my opinion.
No, it is okay because you've done so many. So we wanted to know whether we shall stop using the because of the better results from the
Better results, I can bet you the better results are with this piston.
And another question is, Satish, that when we are doing a revision Stapes,
Yeah.
there forms a mucosal tube around the
Yes,
sleeve.
that is
So
better
how do
fistula.
so how do you handle it when you have removed it and the
Revision Stapes is a different ballgame altogether, I tell you. Revision is always a very interesting situation and you never know what you are going to get. The tube you are seeing around the piston is the sign of persistent perineum fistula. Perineum fistula is always submucosal. And that forms a tube around the piston.
okay?
The,
that remains silent it may remain silent for years and sometimes can lead to labyrinthitis and a sudden sensorineural hearing loss. So, in the revision surgery, you have to handle the oval window very, very meticulously, and here comes the amazing role of laser.
Okay.
See what happens, the piston there inside the oval window, inside the vestibule, and that develops adhesions onto the oval window and inside the vestibule.
Okay.
And it's not uncommon to have the adhesion inside inside the oval window, the piston, adhesion of the piston with the membranous labyrinth.
Okay.
So, to release the piston is the trick. Otherwise, you'll get hearing loss on the table, sensorineural hearing loss.
Oh.
So, dealing with revision cases is always a challenging situation. And the laser in low wattage, you can evaporate the tissue over the oval window.
Okay. Okay.
Find the discrete fenestra. If it is closed, you can make a different fenestra and release the piston from all around meticulously without even touching the piston. And
Okay.
that's the beauty of the laser in revision surgeries.
Okay. Okay. Thank you, sir.
Approaches later on. One. Okay.
No.
Satish,
Yes, sir.
one important thing.
Yes.
Whenever you do stapedectomy,
Yeah.
on table, I am regularly doing Rina test. That is always positive. But when you do Weber test, it gets lateralized to the same side.
Weber test.
Lateralizes to the same side every time.
Okay. Let me tell
There
you
is
the
no
situation.
explanation for that.
No, let me tell you the situation. Patient having unilateral hearing loss, bilateral hearing loss, or the status of the bone conduction in the other ear. All these three things will guide the situation of the Weber's, how it is going to behave in the post-operative period.
No, it is 100% Weber on the same side for your information. If you are not doing,
See,
you are doing today.
that's what I'm coming to, sir. The reason for doing Weber's
Yeah,
is to rule out sensorineural hearing loss.
about what?
So, if your Weber's is to the same side,
Yeah,
that means you have not given a sensorineural hearing loss. That's the only value